On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
I do think that these results are very important and should be practice-changing, and if there are patients that are similar to those that were enrolled in Freedom, those sorts of patients likely should get surgery, unless, of course, they have a very high baseline risk of stroke, in which case intervention through stenting may still be considered.
I think it really is a situation that's very ripe for shared decision-making. This isn't something, I think, where we should walk in the room and tell a patient, you need bypass surgery. And even if the bypass surgery provided the advantage, it's a lot to go through bypass surgery. So this is something where we can sit down with people and say, here are the advantages. It's clear that there are many advantages to bypass surgery, but here's some of the risks and what fits you best.
I think the guidelines are probably going to change to reflect this. I think they should change to reflect this. It's currently a Class 2A recommendation for CABG in patients with diabetes and multivessel disease. I think it would very likely go up to a 1. I would argue that that should be done. And then it's a matter of changing the way that we talk to patients. I think we're going to see more people choose surgery in this instance.
And I think the question I have is, does angioplasty in this setting improve upon optimal medical therapy? So the question is it optimal medical therapy versus bypass surgery? We really shouldn't be talking about angioplasty because it doesn't provide much benefit. Or is angioplasty, PCI, have a place in the middle here? And how do we think about that? So that's the thing I think that's still a little open.
The report from Dr. Lamas and his colleagues was an intriguing biologic observation, but I think my conclusion is that it's not ready for implementation into clinical practice now, but it raised a number of very interesting questions that deserve further research.
Certainly it's a mixture that includes an effect that could be evidenced on the oxidation process, the redox state related to the high doses of vitamin C that are part of the administration of this regimen. And in that way could affect vascular function and the atherosclerotic process. But that is speculative at this point and needs to be tested in clinical studies.
Dr. Gibbons, who heads up the National Heart, Lung, and Blood Institute that funded this study, has to defend it. They spent all those taxpayer dollars doing it. I disagree with him. I think this was a very poor study. It should not have been performed, certainly not in the way that it was performed. The results are not interpretable. We are essentially exactly where we were before the study was done.
The issue here, though, is because of our ignorance about the underlying mechanisms here, although despite the fact that it was used by many people, sort of puts us in a position to say, okay, we have a positive trial where we had kind of a low probability of it being successful. So instead of embracing it as saying this is definitive proof, I think it moves us along to say, well, maybe this thing really deserves a closer look.
When you have a study done by true believers that are that biased and they know who's getting drug and who's not getting drug, the results become essentially unreliable. I would consider the TAC trial to be an incredible waste of $31 million of taxpayer money.
Clinical impact is still premature because we really need to fully vet the results. We need to understand these issues of the relief of dyspnea and what is it about sustainability that didn't occur. And we need to be very, very circumspect about any mortality data in this space.
If the mortality effects are real, and if they're related to an early intervention, that opens up all sorts of wonderful possibilities for new trials and of great benefit to patients. We've never thought that time was of the essence in acutely decompensated heart failure. We knew that time was of the essence in acute myocardial infarction. Time was of the essence in acute stroke. But we didn't know that it was of the essence in acutely decompensated heart failure. And if that's true, it'll completely change the way we treat the disease.
How do we really approach mortality trials in the setting of hospitalized heart failure? That's been very, very difficult to do. It's required large numbers, lots of expense, and longer-term follow-up. We may need to recalibrate what we think and what we accept as a meaningful endpoint for studies like this, so we're not paralyzed by this requirement to show that it absolutely saves lives. Let's show that it's safe. Let's show that it helps patients feel better, and then bring it forward in the armamentarium in the correct way.
I think it's very clear from this study, and I think others have shown it as well, that when we simplify regimens, number one, and when we actually give patients the medication, we hand it to them, we deliver it to their home.
I'm really waiting to see what's going to happen with the outcomes studies because although they're promoting the safety of this approach now, when you get large numbers of patients and you look over longer periods of time, the question will be whether or not this is a strategy that is both effective and efficient.
This is a very important trial because it shows that what we've previously thought was the benefit of defibrillator therapy has probably been markedly understated.
I think the clinical implications, number one, are that we can reduce the emotional stress and the overfiring of these devices by changing thresholds. And again, that's an education process for the electrophysiologist because they're used to the standard set of thresholds based on guidelines. So that's point number one. And point number two, by doing this, we're actually improving survival, which I think is a little bit surprising, but very helpful information.
So the responsibility lies with the physician to choose wisely, to choose how they're going to program these devices, because how much benefit the patient has, how much survival benefit, and how much morbidity they get, how many shocks they get, is completely in the hands of the programmer.
I think if you're a non-cardiologist and you have patients with implanted ICDs, particularly for primary prevention, that could be a patient with an ICD for a sudden death episode or IHSS or end-stage heart failure, for example. I think they should send that patient back to the electrophysiologist with a review of thresholds, a review of the number of times this is fired inappropriately, and presumably adjustments of those thresholds to improve outcome.
We can adopt technologies too soon, that we can get excited about the concept, but that until we test in patients, we really don't know. And I hear people time and time again saying, well, I don't want to wait for those results because I don't want to deprive my patients of the benefit. Studies like this remind us that we can be doing patients harm. And it's not just delaying what is for sure an effective therapy, but we're delaying because there's some possibility it's effective and there's some possibility it's harmful and there's some possibility it doesn't do anything. And we won't know until we study it.